So let's start the discussion of our case. So this is case of 50-year-old female who was recently diagnosed diabetes mellitus since 4 months, probably type 2, we don't know exactly, and she was under medication for it, the combination of glimepiride 1 mg/d and metformin 500 mg/d. And this time she presented to our emergency department with the complaint of easy fatigability and shortness of breath for about 2 weeks. And since 1 month she has been complaining of on and off epistaxis with gum bleeding on and off for 1 week, but no fever, cough, but she had hot intolerance, irregular menstruation, weight loss, palpitation for 3 months. So some features of hyperthyroidism. And so what are the differential diagnoses with these much complaints? So one is easy fatigability, shortness of breath. So and might be due to anemia, just anemia, maybe blood loss or nutritional anemia, whatever maybe, or vitamin B12 deficiency, we don't know, but anemia. And other can be due to heart failure, due to some cardiovascular conditions. Another differential might be, and it does not seem like respiratory system involvement like pneumonia because of no fever, productive cough, just only shortness of breath and easy fatigability. So there is not much point in favor of the involvement of respiratory system. And one point epistaxis and gum bleeding, so that points to maybe due to anemia may be the cause. And another is hyperthyroidism. So hyperthyroidism may cause these types of symptoms like easy fatigability. So that may be another cause. Okay. So regarding her past medical history, I already told that she has diabetes mellitus for 4 months and she was taking OHA, and she also had peptic ulcer disease for 1 month and on taking pantoprazole and iron tablet plus folate tablet combination and salbutamol she was taking for 7 days because of her shortness of breath, easy fatigability. So local medical had prescribed those medications, so she was taking. And regarding her personal history, she was BD consumer but non-smoker, and she was non-vegetarian by diet. And on examination, we found pallor, icterus, but no cyanosis, clubbing lymphadenopathy, and vitals were stable except for tachycardia. Pulse was super high, 140 per minute. And on general physical examination, and bilateral lobes of the thyroid gland were enlarged, and on palpation there were form nodular swelling, and on eye was bulging, suggestive of exophthalmos with wide palpebral fissure, and lead-like sign was present, and infrequent eyelid blinking, which is called still wag signs, and fine tremor of eyelid when asked to close the eyelid. So this is another sign of thyroid eye disease. So and other signs were negative like swelling of the eyelid, bruising of the eyelid, pigmentation of the eyelid, Mobius sign, convergence of the eyelid. Those signs were negative. So I have just mentioned only positive signs. And so with this much history and physical examination, our diagnosis can be diabetes mellitus, hyperthyroidism with anemia. Maybe anemia, we don't know, or maybe heart failure might be hyperthyroidism precipitating heart failure, so that might be one possibility. And on labs we can see this test was done in emergency department, and you can see hemoglobin only 3.9, anemia with platelet only 14,000, and thrombocytopenia, and total count was within normal limit, but total bilirubin was 5.8, suggestive of hemolytic picture, because the LDL was also high, about 506, but direct cum test was negative, which suggests that there is not autoimmune hemolytic anemia. So just only hemolytic anemia with thrombocytopenia. And in emergency department for these lab values and her presentation features, she was transfused 1 pint platelet rich plasma and 1 pint whole blood was transfused. And since emergency department, she was started on IV high dose methylprednisolone, suspecting some autoimmune etiology going on that may be causing this picture. Okay, so but the next day the high dose methylprednisolone was stopped and switched to low dose oral prednisolone tablet, and USG of the thyroid gland was done, which suggests increased vascularity along with enlarged lobes of the thyroid gland with heterogeneous ecotexture of multiple hyperechoic and cystic area. That from this USG picture we cannot differentiate thyroiditis versus Graves' disease, and TFD profile is also not that much distinctive because free T3 T4 ratio is 0.2, so you can say that it is less than 0.3, so we can rule out Graves' disease, it is just thyroiditis. But you also have to consider the sensitivity and specificity of the test if you apply that formula, which is low. And ANA anti-DSDNA was found to be negative, and direct cum test was negative, and RBC in PS4 cytology there was not much any suggestive pictures like cystocytes. There were no cystocytes, but microcytes, teardrops, leptocytes, and transferrin saturation was only 10%, along with corrected reticulocyte counts 0.35. And she was started on propranolol 20 mg/d, and thiamide was not started in view of the low counts, and we are not sure whether it is Graves' disease or not. It may be just thyroid eye disease due to thyroiditis maybe. And next day CBC was repeated with these much medications, and what you see that here you can see platelet increase from about 14,000 to 50,000, and hemoglobin increase from 3.9 to 6.8. And the next day you can see there is dramatic response from 14,000. Here you can see in day 4 1,58,000. Yes, it is very it is within normal limit. Mm. And hemoglobin also reached to 7.9. So the diagnosis was hyperthyroidism. We don't know whether it is Graves or thyroiditis, and presented with hematological manifestations. And another diagnosis is diabetes mellitus, which is probably type 2. And she was discharged on beta blocker, iron folate tablet combination, oral steroid tablet with mixed insulin, mixture of insulin, and she was asked to follow up in 2 weeks. And in this case, thyroid receptor antibody, thyroid scan were not done, so we cannot definitely tell whether it is Graves' disease or thyroiditis. But since her hematological parameters improved with steroids, so one possibility it may be due to thyroiditis, maybe. Or in there are also many literatures they have mentioned even the hyperthyroidism present in the form of hematological alterations as the first manifestations. So she does not have she did not present with other features, but her presenting feature was those bicytopenia. So this can be one of the presenting feature of the hyperthyroidism as well. Okay, with this I like to conclude my presentation. Thank you very much.